Muchas gracias, Alfredo, por la introducción y buenos días a todos. Encantado de estar aquí para hablar sobre la atención integral de salud y el reto de la cronicidad. Pero tengo que hablar inglés. Perdóname, mi esposa es salvadoreño y mis niños hablan español bastante bien, que hay solo 4 y 6 años más y son mejores que yo, claro que sí. Okay? So we speak English. It's better for me and I think it'll be better for you. Okay, thank you. As Alfredo was saying, the International Foundation for Integrated Care, we have a mission to promote integrated care in policy and practice around the world, because what we see, particularly for, as we've been discussing, older age patients and people with complex care needs, that today's systems are both inadequate in terms of being able to support those needs, and also the future is not good in terms of being able to respond efficiently in terms of the financial resources that we have. So we promote this amongst quite a large network now, and it's a pleasure to be here to talk about the challenge of integrated care. So my discussion is very much around people who have complex chronic illness. So you'll see on the slide here, in the top left, was a study from Scotland that was describing, as people get older, the greater likelihood of people having multiple chronic illness. So when you are 85 or more, you have maybe a 5% chance of having 8 or 9 associated long-term conditions. The graph on the bottom left tells us that actually as people get old, it's not necessarily the increasing numbers of people that we have to worry about. People as they get older do not necessarily have long-term conditions. What is happening is that more of these people have more than one condition. So that graph comes from England and it describes about 17 million people across the UK who will have a long-term condition going forward to about the year 2020 and beyond. And it doesn't describe an increase in numbers. What it does describe is an increase in the complexity of the issues that they present with, both in terms of their physical illness, but also in terms of issues of mental illness and dementia. And the other graph tells us that if things don't change, if we don't begin to think through how we change our care system to manage such people more effectively, then the costs, the financial costs of delivering care in the systems that we have today will be unsustainable. So for countries like England or indeed Spain, where we have good coverage and good primary care systems compared to other countries, we're still looking at a cost increase of between 200 to 300% in 30 years, which is not sustainable in the current economic climate. And if you go to somewhere like Germany or France, the costs increase exponentially because they have systems that are not necessarily geared up to support people in communities. And it's not just a cost of healthcare, of course, it's also a cost of social care. As people get older, they will need more care to support them at home, more care to support them in nursing homes and other environments. So it's a particularly problematic issue that we have to face, is this issue of old age and complexity. And perhaps it can be best described in this diagram here. The diagram on the right describes the web of care services that Barbara, who is the principal carer of Malcolm, who has Alzheimer's disease, and she drew this map. She was describing all of the different professionals and organizations she has to deal with on a daily basis in order to get the care that they need to manage Malcolm's illness at home. So she would describe to you 14, 15 simultaneous contacts with the care system, whether it be healthcare, whether it be social care, whether it be the welfare service, whether it be the voluntary sector, whether it be the carers who support them at home. And the problem with this picture is that no one professional group, no one organization is taking full responsibility or accountability for the quality of care that Malcolm and Barbara receive. Everyone is focused on their own particular element. And this is a real problem, because when you go to the better integrated care programs or systems, there is normally someone or some team that has the responsibility. But we don't have that accountability in the system. Everyone is doing individual elements of it. The other problem is that actually they don't communicate very well. This was mentioned this morning. The information systems that allow people to share the information, make effective decisions at the point of care, to help plan collectively, these are missing. And we may have lots of data, and we may have lots of information, but actually we're not turning that into useful resources that we can bring together in order to plan care for people. The other thing I think we do very poorly, and I think this is important for this talk, is that we do not involve the people themselves, Barbara as a carer, or their family, or the community in which they're living, in supporting them to live well. We don't give them the resources to self-care, we don't give them the resilience to cope, we don't give them the education and the tools to support that care at home. And yet that is essential if we're going to move into the future, where 99.9% of the time, the care for someone with a long-term condition at home has to be and has to come from the family and the carers and the person themselves. But we don't do that very well. And the problem with this picture, therefore, is that not only do we have lots of duplication of care, tests that are repeated, different visits to see different doctors for the same types of activity, we also see gaps in care, particularly in the sequencing of events, as people have care that is not coordinated well across the system. And people fall through those gaps. And as you fall through those gaps, poor things can happen. So the result of complexity is that you end up with poorer care experiences to the service users, to the patient and their carer and their family. You end up with a system that has poorer care outcomes in terms of people's ability to manage their own care or manage their own chronic illness, or indeed poorer care outcomes for the system in terms of unnecessary use of hospital facilities, unnecessary institutionalization within a residential home or nursing home. And ultimately, in my viewpoint, therefore, the system is not as efficient, cost efficient as it should be. So we're wasting a lot of resources by not being more integrated. And I think we already know the challenge that we face. Age-related chronic conditions that absorb the largest and growing share of health and social care activities, the poor coordination of care that means we don't respond effectively to that, and we struggle in today's systems with the practical solutions to meet those needs. And the promise of integrated care is that it potentially can meet the triple aim objectives in healthcare systems. How can we turn it round so the problems that are faced in today's systems are turned around to the benefits? So we see better care outcomes for people, we see better care experiences for them, but also we see improved cost. We see reduced costs or improved quality of outcomes for that cost. So what does the evidence tell us when we begin to think through strategies for dealing with older people with complex needs? Well, the first thing is, it's quite clear that our current care systems need to change, and particularly in the relationship between primary care and hospital care. And in most care systems, we have to move from thinking of the hospital or the hospital behaving as if it was a revenue-raising center. We're paying the hospital based on the activity that it performs, and the hospital itself has to be able to live through the generation of the income that it brings in. In most of the care systems that more effectively deal with integrated care and more effectively support people to reduce costs as well as improve quality, that business model is turned around. So the hospital becomes more of a cost center than a revenue-raising center in the mindset of the people planning and delivering the care. Now, there are lots of different examples about how you can do that. And one of the more simple ones is to recognize that actually by taking out some of the activity that could be undertaken elsewhere in primary and community care and focusing in on the more complex cases within the hospital, you can not only reduce cost to the system, but actually you can increase the revenue margin of the hospital because they're doing more activities of higher value for them. And you can reinvest that money in other parts of the system. So there are ways to be able to change the business model without undermining the future of hospitals. The diagram comes from a piece of work that was undertaken at the King's Fund, where I used to work, through Candice Imerson and colleagues, and we were trying to work out why was it that some hospitals had uncontrollable bed use in terms of emergency admissions, in terms of hospital stays, whereas in other parts of England it seemed to be under control. And what we found was, not surprisingly, in those areas which had smaller, 5 or 6, 7 or 8 different hospitals within a catchment area potentially competing with each other, potentially in an urban environment where there was poorer quality of care, where the people in those communities had higher needs and perhaps less educational establishment, and also perhaps living in poorer communities. These were the ones where the bed use was out of control. There was no system to be able to support people to live well, to help educate them to manage their conditions, to support them with good primary care. Whereas if you went to other localities, the market towns, the more affluent areas, the more established general practices, there seemed to be a closer relationship between maybe the one hospital or the 2 hospitals with the community, and a greater ability to respond to chronic care needs as a result, which is interesting. So the hypothesis there is we need to start to invest differently in the way we think about primary and community care. A lot of people will come to me and ask, well, does coordination of care, does integrated care save you money? Does it improve quality and save you money? Well, I think there's lots of evidence to demonstrate that it can improve quality of care in terms of experiences and outcomes. The issue on costs, I think, is slightly more difficult to come to. But this paper comes from the Karolinska Institute, from John Overettveit, published by the Health Foundation, that has some excellent resources in the UK, freely downloadable. And what they say is, yes, better care coordination can improve quality and it can save you money, but it very much depends on how you deploy your interventions. Because there are lots of interventions that support integrated care that are costly and many that actually don't improve outcomes. We know that disease management programs focusing in on clinical quality for people with specific diseases improves quality and is more cost effective. Doesn't necessarily reduce cost of the whole system, but it's certainly more cost effective. But we also know that effective case management schemes for the complex patients in the community involving primary care, community care, social care, and other providers, housing, welfare, leisure and community and voluntary sector, these can also be very effective in supporting people well. One of the essential components of this, though, is to also begin to support people to live well within the home environment. So in other words, with the tools to manage their own care, and also the ability, greater ability to manage their medications. Because when we start talking about older people with complex needs, the issue of polypharmacy, the issue of conflicting drugs, the issue of managing those medications is extremely important. That requires support and help to people. What the evidence also says, however, is that we have a lack of robust evaluation to tell you what sorts of interventions will work in what circumstances. Thank you. The evidence will also tell you that when you start to bring together your networks of care providers, your GPs, with your community staff, with the community sector, with the hospital, with local authorities, money that might be saved in one part of the system might necessarily lead to a financial advantage for a different part of the system. So it can be very difficult to build the sorts of alliances that you would need between your care professionals and between your organizations because of that purpose. So it can be very difficult. The third thing that you find in the evidence, it's actually really very difficult to start to put quality regulation on a system that involves all of these different organizations. Because in integrated care for chronic illness, you would need to talk about regulation for quality across a whole range of different providers working together. Whereas, of course, the regulators focus on professional quality or primarily on regulating particular institutions, because that's what you would need to do. It's much more difficult to start thinking about how do I regulate a system. So this is a problem. The other key thing from this work is what you find is that care coordination is most important to people who live in hard-to-reach areas, to older people living in difficult circumstances, to people living in lower socioeconomic groups. These are the ones who would benefit the most from care coordination, but actually they're the ones who least receive it. So there is an issue here when we start to develop strategies for supporting care coordination, integrated care to people with complex needs, is not to focus on the areas that are already well served, but to really begin to focus on those areas which are difficult to reach and manage. And I'll give you a slide later, again from a Scottish experience, that will explain why that's important. Here's another paper you can go to. This again comes from the King's Fund. And like Spain, we don't have any more money to spend on healthcare. So we were asked at the King's Fund, what would be your 10 top strategies in order for us to get the best return from our financial investment? And it was really a group of experts who came together to suggest them, and there are 10 that are up on the screen there, but they really fall into 3 categories. One is we need to focus on supporting people to live well, so that is about supporting them to self-care, and it's about primary and secondary care prevention. The second key strategy is investing in primary and community care facilities in order to support that. So investing in primary care so that you're able to reduce the numbers of people with ambulatory care-sensitive conditions, in other words, conditions that could have been managed in a primary care setting, and stopping them becoming a hospital admission. It's about supporting good medications management in the community. It's about developing teams of health and social care to enable people to live well. And a really key important one here is bringing together services that support people's physical health, their physical chronic illnesses, heart failure, diabetes, COPD, with issues related to mental health and well-being. Because we know that if you have 1 or 2 long-term conditions and you also have associated depression or anxiety, you're at least 4 times more likely to be a cost to the health system and at least 8 times more likely to become hospitalized within the next year, according to some of the good services. And yet we don't tend to integrate behavioral services, mental health services, at the point of care, which is really important. The third key strategy that comes up is actually we need a much better sequencing of events when people receive care, whether it is elective care services through to the hospital or indeed for emergency care services, because we find that these sequencing events, this coordination of care, these care transitions are very poorly planned and managed. All you have to think about is an older person within a hospital and the difficulties that you would have in getting that person back home in terms of the discharge elements, in terms of bringing them out of hospital. So these care transitions, particularly from hospital to home, are normally extremely poorly managed in most countries, and this is where an awful lot of the need is. So a couple of slides just to say 2 things. What's really important in this then is to really take the agenda to people and help people to manage their own care. And there's lots of good evidence for how you might be able to do that in terms of shared decision-making, individualized care plans, health education programs, telehealth and telecare and new technologies. Again, this is a resource from the Health Foundation that tells you that. But it's not just about individuals and their carers, it's also about communities. And I'll come on with some examples in a second. I'll give you some case examples. But community participation in terms of planning and goal setting, in building community awareness in terms of the importance of health education, building social networks so that the community is more cohesive and understands how to respond to healthcare issues, and actually involving the community as assets, looking at the people in the community, and particularly those with diseases, as people who can help you to deliver the care, to spread the message, to actually be another part of your care system. And this is really important. About 2 or 3 weeks ago, I was in Kazakhstan, and they have ambitions to build a social health insurance, and they want to build a strong primary care system. But what's very clear from the politicians and the planners is they look at the population as a problem that needs to be solved. The relationship is very poor. They see lots of people demanding services who refuse to take responsibility for their actions, who don't recognize the difficulties that general practice has in dealing with that demand, that are somehow therefore in this adversarial relationship. And that's not good, because if we're going to move to a situation in order to be able to manage costs, we need to turn that around so you look at this group as your assets who can support you in delivering the care. And I'll come up with some examples. Another important one that comes from the literature when you start to talk about older people with comorbidities, and this is a systematic review of interventions in primary and community care for people with comorbidities from the BMJ, is the more effective approaches are looking at holistic needs, so health and social care needs, the environment, the family, the housing, but actually focus on more of the social care side. How do we support people to live well with their conditions rather than aggressively manage the diseases that they've got? How do we enable people with the resilience to cope in managing medications and in difficult circumstances rather than necessarily targeting specific illnesses? And I think that's very important, because when it comes to people with complex issues, it's often these social interventions that are much more effective than the medical ones. Here is another slide, now quite a famous slide now from a landmark study, again on the city of Glasgow. And all of this describes to you, these circles, they looked at the admissions coming into Glasgow hospitals, and they looked at them in terms of the presenting disease. So some of them will have coronary heart disease, going down there's diabetes, COPD, and cancer were the 4 that they looked at. But what they found, of course, is that people don't just present with a disease, they present with a whole range of other issues as well. So they saw the percentage chances of people coming in with coronary heart disease or cancer, also having anxiety, depression, other painful conditions. So this is not just describing to you that people have comorbidities. What they also found was that the prevalence of this complexity was much more prevalent in the poorer communities of Glasgow, where people were actually presenting with complex conditions much more early in life. And actually, when you look further into that, you recognize that the propensity for your next chronic illness patient within the hospital is really significantly affected by the localities in which they live. So this goes back to that point from the Karolinska Institute report that I showed, that shows that care coordination is much more effective to those hard-to-reach groups. This is telling you another story that's saying actually the largest cost to your hospital sector are coming from patients who have probably had an experience of living in poorer communities with low educational attainment, maybe with issues related to drug and alcohol issues, maybe poor housing. These are the communities which have the greatest need and will be the greatest expense. So therefore we need to think about quite seriously, not just looking at health and social care at the back end in terms of managing people who are already sick, but beginning to think of integrated care as a public health enterprise where we can involve communities and other approaches that can support communities to live better. So it's thinking about health and social care as part of a public health system. So to conclude on this one, and then I'll give you some case examples because I know we're slightly short of time. It's about developing a different business model for the system, particularly for hospitals. It's about being proactive in the management of care to people in communities. It's about supporting investments in primary and community care to enable that to happen, so building skills and capability. It's about the better coordination of care in the care transitions across the system through the use of good information and protocols and so on. And it's also about thinking through who you're going to target most effectively in order to be able to get the results that you need. So let's have a look at some case examples. I'll take you first to the UK. And I'm not going to talk about the pioneer programs and the other things that are coming on, because we'll hear more about that tomorrow. But at the King's Fund, we did a study about 2 years ago, and we selected 5 case examples that had demonstrated triple aim outcomes, that improved care experiences, that improved care outcomes, and they'd reduced costs. And that's the study that you can download it from the King's Fund website. And I'll give you a couple of examples. There's too much to read here, but I'm going to tell you what they were saying. So this is South Devon and Torbay, which is a very famous example in the English context. And originally, they had a pilot program where they thought, well, we need to start to work together because we see too many older people who end up in hospital who don't need to be there, and in fact they stay in hospital for too long. There's no system to get them back home. The readmission rates are very difficult. This is a poor care experience and it's very expensive. So the first thing that they decided was, we're going to have health and social care teams working in community to support people as they come out of hospital, to give them rehabilitation and support, to enable them to live more appropriately at home after a hospital admission. And key to that was having care coordinators who would be linked to these individuals, targeting people over 75 with complex needs, and having them, and these were lay people, these were trained lay people, they were not nurses or doctors. And they would sit alongside these people as they had the experience through the hospital, and they would see what was happening to the patient, they would liaise with the family, but they would also liaise with the discharge team and also the home care team, and bring these people back out quicker, so length of stay really reduced, to a team that would support them in the community with rehabilitation, so readmissions also reduced. This study shows that they also wanted some front-end capability to actually reduce admissions in the first place. So they introduced, they used all of the data that they had to have a risk stratification system so that they were better able to understand who was most at risk of a hospitalization within the community. They focused very much on having proactive outreach to localities or individuals or families who they felt were at risk. They enabled, what was very important is that they enabled a holistic care approach, so that they were focusing on people's range of needs, not just their long-term condition, but potentially how they live. So a lot of this was about warmer homes or welfare advice or assisted living within the home to support people from stop having a fall or falling into crisis. And a big issue here also was dedicated care coordination. So every individual in that community would have one person that they could call in a time of crisis. And they also had this idea of something, how you translate it into Spanish, but something called advanced simplicity. Because what kills case management schemes is when I have a problem and I go to see an older person within a community, and I have to go back to the GP, and then the GP has to initiate a response to another part of the sector, so you end up with lines of accountability that make it very difficult for an immediate response to happen. In advanced simplicity, anybody can refer to everybody else. It doesn't have to go back to the GP for sign-off. You can go from the mental health nurse to the social care physiotherapist, through to the nutrition advice, through to the befriending scheme, and it works in a much more networked fashion, rather than having every decision having to go through one particular person, which slows things up immensely. And that's really important, because for older people living at home, to stop bad things happening, you have to get in early. So you need to have fast and efficient and flexible systems. This is another good example from this study. This was looking at end-of-life care in a community south of London, an English kind of rural community. And they had a real problem because they had a voluntary hospital that closed overnight. It had about 12-bedded palliative care unit. So they had to try to find an alternative for their end-of-life patients without hospitals. So they introduced a consultant-led, community-based palliative care team, which had a nursing complement and a couple of consultants working in the community, but also a whole range of other multidisciplinary teams to be able to have a multidisciplinary response and to support end-of-life care at home. And that's the care pathway on the left. But what was really important here was they had to raise awareness amongst all of the different partners in care in that community in order that they could understand who was falling into crisis and who might be nearing their final days. So this was not just the GPs who could do a referral. It could be neighbors. It could be a family member. It could be the social care staff. It could be the voluntary sector. It could be the community group. Anybody could refer in to a center where an alert would be raised from the nurse, and then a response would happen. Let's go and see this person and see what's happening. And then they would make a decision as whether to refer it back to the GP, as a green flag, an amber flag, so well, let's do some watchful waiting because this person's okay, might need some support, or actually a package of care is introduced. And what was really interesting when you start to look at the evaluation of this, in the Midhurst model, so on the left-hand diagram, the green bars, they were able to see an awful lot of people without them having to go into hospital. So the numbers of people that they were seeing within their cohort had never really had a hospital admission. So we're talking maybe 53%, 60% had not had a hospital admission. Whereas those who ended up, this is in the last year of life, but those who ended up either dying in a hospice or dying in a hospital, they were much more likely to have 2 or more admissions to hospital. And that's really important because when you look at the financial evaluation on the right-hand side, we were able to see that the Midhurst service was saving maybe £2,500, about 20% less costs per patient at the end of life. And that's not because of the cost of end-of-life care at the home is cheaper. It's not. It's much more expensive. It's because you've been able to reduce the numbers of admissions to hospital beforehand. That's where your cost savings happen. You're stopping bad things happening, exacerbation of problems, so people have to go to hospital, and that's where you save the money. So if you multiply, 500,000 people die in England every year, and you might be able to save 2,000 per patient based on this kind of analysis, you can do your own mathematics as what the potential of this kind of approach is. And in fact, this is being rolled out by Macmillan, who is the cancer charity in England, as their model of care based on this. And also, the families, you could be an extra burden, couldn't it, to have families looking after loved ones at home at the end of life. But actually the evaluations are really very positive because this is exactly what they wanted. And something like 99% of cases, people died in the place of their choice, which is either at home or in a hospice. Very few people want to die in hospital. Whereas across the whole of England, the numbers of people dying in a place of their own choice is around about 44%. And most of still very high proportion die in hospital. So it was very successful. So this is a triple aim outcome. Let's have a look at some international examples. Again, this is a King's Fund study that looked at 7 case examples of dealing with people with complex needs. So again, we can go to the websites and read. This is a very similar example to Midhurst. This was the Geriant project in the Netherlands. And this was a group of geriatricians and GPs who were fed up with the quality of care that people with dementia, particularly with advanced dementia and towards the end of life, were receiving. There didn't seem to be any particular services to support people at home. So they created their own little social enterprise, their own little company, which actually was quite simple. It brought together a multidisciplinary team. You see it on the right there of a case manager, social geriatrician, psychologist, and they would attach themselves to different GP practices as a service. And the GP practices would pay for them to be part of that. And when the GP saw someone who had suspected dementia, they would refer that person to the team, and they would do an assessment and thereon have them as their caseload. And of course, people with advanced dementia often fall into crisis, and often it's very difficult for the family members to cope and so on. So there was also a crisis response team to support care at home, to support respite and so on. What the evaluations of the Geriant project showed was actually the costs to long-term care when you added in the primary care support component, we're about 47% less in this study. And the Heriamp project now looks after 30,000 people in different contracts across the Netherlands. So it's grown primarily in the north. But it gives you a good example of what you can achieve in terms of both. And again, the satisfaction surveys from families were really very high. People were more able to manage care to their loved ones at home. And what was specifically important to this in the previous project is actually a lot of the emphasis is on supporting the family members and the carers, the spouses, to cope, giving them the tools to be able to manage someone with complex needs at home. Here's another case example. So now we go to Sweden, and this is Stockholm County, and in the north of Stockholm, right at the north there, is a place called Norrtälje, which is about 56,000 people, and is a community, I guess you might say, in slight decline. So it has an older age population, the economy is not doing so well, has problems with youth, drug and alcohol addiction, there's not a huge amount of economic growth. And what they decided to do was take the municipal council with the county council, basically bringing health and social care together as a planning authority to start to think about how do we manage these public health problems more effectively. And really they just came together to have a discussion. This is the Swedish way of doing things. We're not going to change the system. We're actually going to come together and have a discussion, and we'll all go away and we'll do our service a bit better. We'll communicate better. We will change our referral pathways a little bit better. We're not going to be funded different. We're just going to do something different. But in this one, they were able to focus in on two communities in particular. One was older age people living at home, and the other one was on mental health care in youth and community. And they developed, through the pooled budgets that they had, specific services, multidisciplinary services for those two communities. And for the older age group, they've been able to support people to stay at home for longer. They've reduced hospital admissions a little bit, not much, but actually they've been able to reduce long-term nursing home stays quite a lot. So some good outcomes from this project, and it comes from a project Integrate, which I'm involved in as an EU study. I take you across the world now to New Zealand. So here we are in the north of New Zealand, and there's a large bay called the Bay of Plenty. This is after Captain Cook. So on the east side, there's a bay called the Bay of Poverty. Captain Cook landed here in about 1780, and the Maori community didn't like him much, and there was a bit of a fight, and he had to leave, and he wasn't able to get fresh water. And he went round the top of the island and reached a place where he was able to find the Bay of Plenty. But in the Bay of Plenty, there's a significant Maori community with quite a lot of complex long-term health needs. And within this community, they focused about, in the Maori community, it's very interesting because you're not able to get access to people through traditional healthcare systems. They work in terms of what's called a whānau ora approach, and the whānau ora really means the extended family. So I can't have a discussion with you as a patient without actually also involving the rest of the family in that discussion. Nothing is going to be done in terms of an agreement in how I will manage my care until the whole of that little community agrees. So that's not going to work in a traditional doctor-patient relationship. So it's about developing a different way to engage a hard-to-reach group. And they had to work with the whānau ora and the family through non-medical, nurse-trained individuals to support people to understand how they're going to go about improving their health care. But they didn't go about it by saying, you're overweight, you have hypertension, you need to have these types of activity. They went it in a different way and said, well, what are your goals in life? What do you really want to achieve? And how would improving your health enable you to support that? So a lot of people were not even able to get out of their houses. A lot of people had really significant chronic conditions that they ended up in hospitals too many times. So they would explain to you, this is how I would really like to live my life. So they ended up with a care plan that was based around the goals that they would want in the context of their life. But the interventions were much the same, of course. Dietary advice, supporting people to manage their illnesses. But the motivation for the people was different. And they've been able to demonstrate, particularly amongst people with respiratory illness, greater capability to manage at home, reduced hospitalizations, and an economic analysis. I wouldn't say it was particularly robust economic analysis, but they were able to demonstrate that the cost of their system hasn't increased as fast as like care systems in other parts of New Zealand. So they've been able to restrict the growth in costs to this population. I take you back north now to Finland. And again, this is a rural community in the south of Finland called Eksote, or South Karelia. And here, again, they have a lot of old age community, lots of people with complex chronic illness living in rural communities and hard to reach groups, quite close to the border of Russia. So this is a community 200 kilometers apart, about 130,000 people, with very distinct local communities and community groups. So how am I going to be able to manage this group when they don't have access to hospital, they have pretty poor access to primary care, there's a lot of social isolation and so on. So what they did was that they built the capability around the local neighborhood districts, and they engaged the local community groups and they engaged the local councils to start thinking through what is it that we would do to design services better for you. And they said, well, what we really would like is a wraparound service that did health and social care and welfare advice that came to us so we didn't have to go to them because the distances are too high, and that would really help us manage our care. So they came up with a solution that would support, so in response to that, the health and social care providers came into a new provider organization, an integrated care organization of health and social care to deliver care jointly. And they developed a mobile model whereby they used mobile phones and telehealth and telecare to connect in with people in these rural and remote communities more effectively. And they also used things like this. They would take a mobile van with a nurse-led service, and they would drive around the community. They also do it with boats as well, because people are living on islands here. And on there, they would also have electronic records, so people could see what was going on. But they would agree in advance which community they would go to. So the community group would actually engage local people and have some sort of event, so that actually people would be available to come and have a checkup with the nurse in this mobile community. And over time, they've moved from supporting older people with particular chronic conditions. Now they have physiotherapy, they've got dentistry, they've got podiatry, they're supporting people with health coaching. They're really growing the range of different services that these nurses can provide in these mobile clinics, and they're supporting people with more electronic equipment to help them manage at home, with some good results. I think they found it more difficult to engage the men in their community than the women, a cultural issue with Finnish men, I think. And that is an issue, because a lot of this you require activated patients and communities, and quite a few of the communities they found quite hard to engage. I'll give you one more example and then we'll wrap up with some conclusions. I'm now going to take you to Alaska, and this is a really interesting study. It's one of the most exciting ones I've seen. And what happened in Alaska, this is a native community of 60,000 Native American Indians, and they actually took over their running of their entire health system. Legislation in the United States enabled them to do that. So the entire community said, we're going to run our own healthcare system. So the community now actually owns and operates the own system. So every individual, every patient is a consumer owner. They own the healthcare system. And what's really interesting in that is that they recognize they only have a finite amount of money for what we can do. So what's changing is how they want to access care, and they have an understanding that it's about, I need to manage my own health. So it's really interesting when you go to the practices here, is that the GP is off to one side. Most of the rest of the healthcare team are, they're social workers and physiotherapists and nurses, people providing mental health advice, and the GP is a specialist sitting in the background. It's not a doctor-led system. But the other thing that happens is when you go in for a consultation and someone says, I'm not feeling very well, do you think I could have an antibiotic because I have this chest infection, I think? And then the doctor would say, well, we can do that, but first of all, let's have a conversation about you. Let's have a conversation about why you're feeling anxious. Let's have a conversation around you in the context of your life. And it was this kind of building of a holistic view of their population that enables people to think, well, actually, you're right, doctor, I need to take some further responsibility for my actions in being a consumer owner of this organization. So it's really interesting what they did, and A lot of it wasn't integrated care. They really invested a lot in primary health care, in access to care. They brought behavioral services, mental health services alongside primary care in one place. So they were able to see a reduction over time of something like a 4-week wait for an appointment to see a mental health specialist down to 0. And you can see on the left-hand side some remarkable results in terms of a 36% reduction in hospital days, 42% reduction in emergency admissions, 58% reduction in access to specialist clinics. And people like working there, so staff turnover is also reduced 75%. So we're getting really good results from this system, partly because you're investing in more primary community-based solutions that are culturally sensitive to the people who want to receive it, but also because you're engaging the population directly in terms of their understanding of how they should behave as part of that care system. You might say, what does Alaska mean for Madrid? Well, it's a good question, but I think some of the principles of engaging populations are there. So a couple of last slides. When we start to think about, well, how do we fund and incentivize this then? I think if you want to gain these sorts of outcomes, it has to be all about building alliances. In order to be able to deal with older people with complex needs, it's more than just a health question, it's more than just a social care question, it's about housing, it's about the voluntary sector, it's about all of the different assets that you can bring from the local community in order to be able to build capabilities to manage that population. And this can only really be done by building alliances between these organizations. And often that means you need to have some sort of governance, so people will agree to be governed or led in some way, and that might mean new collective agreements and new incentives that are shared collaboratively across the group, but it doesn't necessarily have to be like that. And here's a really interesting example from Germany, the Kinzigtal example. It's about a population of about 50,000 people in the Kinzig Valley, growing older, significant issues with chronic illness, and they've really demonstrated the ability to improve life expectancy, improve quality of life for their citizens, reduce hospitalizations, and for the last 2 or 3 years, they have been able to reduce the comparative costs in their system compared to a case mix adjusted other parts of Germany by something like 150 euros per person per year. So that's about 4 to 4.5 million euros per year that they're saving compared to what's happening on the rest of Germany. And what they have done is they've not changed the way that people are paid whatsoever. What they have asked people to do is come together to have some sort of gain share arrangement that says, if you take forward these types of health promoting activities in the community, as a hospital, as a GP practice, as a leisure club, as an industry in terms of workplace schemes within the schools, if you come into that arrangement, we know that the insurer will give us some money based on the savings that we'll make, and we're going to redistribute those savings in order to be able to improve health in the future. So it's a gain share model. So nobody feels threatened by the fact that you have new financial mechanisms, and everybody has something to gain because we recognize that by working together there's a possibility to reduce costs. And it's worked very well the last few years and continues to do so. And lots of examples, lots of literature on that. So the issue here is when you start to look at the case sites that I've described, what's the balance of the funding? So this is the cappuccino model. The chair of my organization, Hochschreibers, has written a book. It's in Dutch only, I'm afraid, but it's called the cappuccino model. And he suggests that when you look at the better integrated care systems that look at communities, something like 85% of the money is the coffee in the cappuccino, which is a capitated budget based according on local population needs. Because often our systems look more like latte, where actually more of the money is based on financial incentives and other sorts of outcome-based pay for performance. But he would say maybe the froth in the coffee, the milk, is maybe another 10%, and that's based on pay for outcomes, pay for performance. And we need to leave a little bit of money to fund incentive and innovation. So the balance is moving towards more population health-based capitated payments with less of a focus on pay for performance. And when you look at the examples that I provided too, they've all moved in that direction to support a different type of funding approach. So 2 slides to conclude. So in summary, I shall read my own notes here. I think that strategies that support people-centered care in particular and have a population health perspective are clearly, for me, the strongest in being able to try to achieve those triple aim outcomes that we discussed earlier in terms of better care experiences for people, improved care outcomes, and more cost-effective care. Across the different case studies, I think we find that holistic care, or care that's not dominated by the medical paradigm, tends to work better, particularly for the aged, complex cohort. Building activated patients to self-manage is important, but more important than that, or just alongside that, developing communities to be assets rather than issues to be dealt with. These are assets in which you can bring into the system. So we have other things like interdisciplinary teams, looking at the harder to reach groups where most of the demand will come from, case management of complex cases, and having an integrated delivery system that's actually responsive. Too many times I see really interesting case management projects, which has health and social care working together and everyone gets on well, but actually they have a very limited set of resources that they can have. And then outside of the resources might lie physiotherapy or might lie some sort of mental health specialist, and the waiting times might be 6, 8, 10 weeks. Well, that's not much good when you're trying to get a real-time response to somebody in need. So the final one, these are my kind of takeaway 7 key lessons. And actually it's been written up in a book chapter, in a book that was actually, there's a Spanish version of this that was published here in Madrid. So one is we need population health management. We have to have an ability and an in-depth understanding of our local health needs of our communities and use that data proactively. Secondly, you need a primary and secondary care prevention. So you need the ability to support people and communities to live better with their conditions. So prevention being better than cure. Thirdly, we need personalized care coordination so that there is an ability to coordinate care and activity across the sectors more effectively, reduce fragmentations. We need effective information and communication systems so that people can talk to each other more effectively and particularly make better decision-making at the point of care. We need an integrated delivery system that has the opportunity to respond, because when you talk about complex chronic patients who are old, there's no such thing as usual care. It's very difficult to define a basic package of care. Really hard. Everyone is different. So if we're going to have a response to that need, we need to have some sort of system that is flexible enough to respond. So you need an integrated delivery system if you're going to be able to achieve that. Really important for me, that I'm a social scientist, is how do we build social capital? How do we build a philosophy and a cultural understanding that this should be the way forward? Because actually it's not shared. Politicians find it very difficult to speak about imposing greater burdens on individuals in order to manage their own care and closing your local hospital to do something different in primary care. Regulators find it difficult to do something different than regulate institutions. Professionals find it difficult to work in multidisciplinary teams when maybe their own professionalism is undermined. Patients also can find it extremely challenging if you change the way that they think about care from, say, a long-term relationship with your local GP and change it to a group of nurses who are coordinating your care needs differently. So it can be very different. Everybody is challenged by this agenda. So you have to have good discussions, good communication so that everybody understands and values that this is the way forward. Because most people won't accept it at face value. And finally, we need to research and evaluate it, because actually although I presented what I hope was a coherent argument, there's a lack of research and evaluation studies that would allow me to tell you, those of you who are holding the money, how much return on your investment you would get if I invested in this particular project in this particular locality. Really difficult to do because the process is extremely complex. So we need more research and evaluation to be able to demonstrate the outcomes that can be achieved, but also to support implementation so that you have greater understanding or you feel more secure in the investments that you're making. So these are the key challenges. Alfredo? Finito? Ok. Gracias.